Good evening. This is Dr. Ravikant Patil from Mirrors. I thank organizers for giving me opportunity to share my cases in this prestigious conference. I'll be talking with the calcium in the coronaries. We all know that calcium and the thrombus are the two main important enemies of interventional cardiologist whenever we deal with the interventions in our cath lab. The calcium can present in a various way. It can be just a stick of a calcium into the coronaries to a heavily calcified coronaries, and we need to deal with all these things. So I am be presenting few of my cases regarding the calcium in the coronaries. To start with, it is just a minor calcium in the left main. It's a left main bifurcation lesion. As you can see, there is a calcium streaks in the proximal left main as well as the ostial and LAD and the circumflex. It's a simple bifurcation stenting at the left main, and you can just get out with any of the uh, any of the uh, uh, method of the intervention. Like you can go for the bifurcation for this vessel. I decided to go for the bifurcation stenting for the distal left main, and similar tricks as you can see that we decided to go from left main to LAD, and then the bifurcation stenting. The first deployed the left main to LAD stent, and then recrossing, and then the circumflex stent, and then the kissing balloon at the left main, and then proximal optimization technique. And this was the final result. So this is just a simple calcium dealing at the left main. You did not to go for the cutting balloon. You did not to go for any high-end equipment. You can just go with your routine balloons. You may have to go with the NC balloons to dilate at the higher pressures. You may not also require to use the OPM balloons also in these cases. But then it can present in a various ways. Sometimes it just presents like calcium, which is the chronic occluded vessel. There is acute on chronic. As you can see there was no flow at all into the LAD. There was a total cutoff. There is a calcium. There was a chronic lesion, and which was presented on acute and chronic coronaries lesion here at the ostial LAD. I started using the XTA with the microcatheters in this case. I couldn't see the further, there was no flow. I could cross with the help of the microcatheters and the XTA wire. And once the microcatheter inside, I changed the wire from XTA to simple working horse BMW wire, and then dilated the vessels. And just for a protection, another wire at the circumflex, simple left main to LED stenting, and then there is a distal LED stenting. So you can see this was the right hand side. This was the coronary completely occluded at the ostia, and this is the result after crossing the wire in this occluded coronaries. Then the calcium can go into a different way. Then there will be a severe calcified lesion. It can be this man who was 86-year-old. Proximal LAD has got a very tight lesion. Even I tried with the 1.5 balloon. So I couldn't cross the balloon there. And then I thought of using the simple Rota 1.5 bar lesion, and then a routine balloon, and then dilatation of the lesion, and then finally putting a stent. So sometimes Rota in this kind of lesions is very easy. You think Rota ablation is very easy in this kind of cases. You just go cross the LAD, put a bar there, and then come across. But then Rota can be a nasty in the cases where the lesions are very severe. If you can see, she was a 48 years old lady, severely coronary, small vessels. Patient was not at all ready for a CABG. There was no other way to and go ahead and do a stenting. I saw the lesion at LAD and circumflex. First, we thought that we'll go and dilate the work on the circumflex. There was acute angles both at the LAD ostia as well as the OM. Tried to cross balloon and then stand, couldn't cross. So thought of doing a rota. There was an angulated case. There is angulated branch. Did a rota with the 1.25 birth there. There is a fine opening of the vessel as you can see. Then we dilated the vessel with the 1.5 and thought of putting a stent there at the circumflex. Dilated the stent. After dilatation of a stent, you could see there is a huge perforation at the circumflex. The patient was really in a hemodynamically compromised state. There was a pericardial effusion. There is a huge perforation at the circumflex ostia. I tried to cross a cover stent there, but the cover stent was bulky. It couldn't be negotiated across those lesions, so couldn't cross a cover stent there. Patient continued to be hemodynamically unstable. Tried crossing a balloon up a 2.5 NC balloon. Kept balloon there for almost half an hour, and then uh, there was no other way for me because I couldn't cross the cover stent also in these cases. So this was occluded by the balloon, reversed by the protomin sulfate, and after some time, I'll just go back. And after some time, if you can see the report after 30 minutes, vessel closed, abandoned the procedures, and then sent the patient to straight away to the CABG. So ROTA, if not used properly, or sometimes these kind of a small vessels, even if you are expert operators, can cause this kind of a complication, and then you need to deal with the complication with a different way. So use your ROTA with very, very cautious hands. So after this experience of a ROTA, for next case with a calcified coronaries, I thought of using the new shock wave lithotripsy. You can see this lesion. There is a mid LED heavily calcified, diagonal was heavily calcified. We thought after our previous experiences, we thought we'll use the balloon, that is the shock wave lithotripsy balloons. So first dilated the mid diagonal lesion, and then you can see this was the 3 millimeter 3 millimeter shockwave balloon used, given a 10 pulses first and then repeated 10 pulses again. The lesion could give away. If you can see at the third frame, the lesion gave away, and then the nicely opened LAD, nicely opened diagonal. Then there was another lesion at the diagonal ostia. Again, we crossed the balloon, that is the shockwave balloon, and then dilated the ostia at the diagonal. Both LAD and diagonal ostia we dilated, crossed the diagonal stent, did a bifurcation stenting at LAD diagonal as usual by the routine methods. This was the diagonal to put first, then dilated with the balloon, and then LAD, and this was the LAD diagonal. There was still diagonal was not dilated properly, so we crossed the balloon again, NC balloon there, and dilated the lesion. This was maximum what I can achieve in these cases with both LAD and diagonal open. We use here as the balloon we use the shockwave lithotripsy as the method here. So we have different methods to deal with the calcium. You can just go away with the non-compliant balloons to cutting balloons to you can go with the rota ablation. You can go with the shockwave lithotripsy. So we have different approaches for the all this calcium in the coronaries. Use judiciously. used properly in all the cases, we can definitely will able to come over with these difficulties when we deal with the calcium in the coronaries. And I think with this, with new balloon lithotripsy as well as the rota ablation, we can definitely help patients with all these new technologies. So thank you very much for the patient listening.
Ravindra, excellent cases. You showed very good cases, but I just want to tell you that about the rota case. When you have a bend, in the artery, the burr is usually biased by the wire. So as the wire goes, the burr will go accordingly. So when you have a bend, you must move the wire. Release the brake and move the wire. Other operator has to move the wire so that the bend is negotiated well, and you can cut the calcium, ablate the calcium at the bend. That is the one precaution that we should take when specifically, and the speed of rotation should not cross more than 150. Especially at the bend, you should be slow, and picking should be very slow. That is the only thing that I thought could have prevented the perforation. And second thing, the first case that you showed, I think the ostium of the circumflex has not opened fully. So it needed a cutting balloon, and otherwise it will come back as a, we know that Achilles heel in the leptoplasty is restenosis in the circumflex ostium. So it likely to come back after a short time. These are the two comments I thought I'll make it.
In the circumflex, yes, sir. In the circumflex rota you did, was it a 1.25 burr or was it a 1.5 burr?
1.25.
It was 1.25 burr, sir. And perforation. Perforation was.
Yes,
yeah,
yes.
The perforation was not after rota actually. Perforation was after the stent actually. After the stent, I expanded the stent and I actually miscalculated the size of the vessel. So I over dilated and then it gave away.
It sometimes happens when you dilate at a high pressure. The calcium may restrict the stent expansion at one side. The other side, there is an uneven expansion and it may produce a perforation. I just wanted to know one thing. When you did two IVLs, one IVL in the LAD and one IVL in the diagonal, did you take two IVLs or the same IVL you preserved some of the pulses for diagonal?
Actually, I use same IVL, sir.
Right, because cost constraint. That was because it is prohibitively costly when you use two IVLs. Yes. Fortunately, the diagonal and LAD was of almost similar size. Otherwise, IVL works only if it is a 1-to-1 balloon to artery ratio.
Yes.
I think good cases we can have next session.